So are we connected? Good evening all. So I think we are connected now. So we'll wait for another 1 minute and then we'll start. Well, so starting with the class now, I can see that many of us have joined now. Uh, so we have more than 120 students now. So I'll start with this revision class. Good evening all. And I think last time the class went little bit longer. So today I'll keep it short itself and cover all the important things for all of you. Okay. So we were discussing previous year's papers also, and together with those previous year's papers we were revising all important things, like we were doing the rapid revision of OMR also, along with discussing the papers of last year, right? So I'll just take up one slide first before I go to the next questions, and that slide is important, so I'll take that slide first now. Before that, so I'm sure the screen is visible to all of you. So So I told you that we had a lot of questions on developmental disturbances, and I also told you that we'll discuss the developmental disturbances in the slides in the next class. All right. So all of you are able to see this slide now? Yes, I'm sure you all are able to see this slide now. I am also able to see this. So I'll just use this. Yes, I'm fine. I am little bit not well, but yes, I am fine that way that I'll be able to take the class. Not to worry. Thank you for that concern. So all of you can see this slide. I can also see this slide here. Just give me a minute, I will start. Yes. So students, by now you all know that what do we see on this slide? We see this on this slide, dens invaginatus. You all know this, that on this slide we are able to see dens invaginatus. So now while going through previous year's papers, I am sure you must have seen that there were two questions that are asked, that paper bank which was sent to you. Usme you must have seen that there are two questions which are asked related to dens invaginatus, right? One was to identify the pathology, right? And I am very sure by now all of you are well versed and you all can identify the pathology well, isn't it? So you can see here, this is, I am sure it is seen on the slide very nicely. This is the most common IOPA which you see here. This is the most common IOPA what you see here. This image you will see everywhere while you will be solving the questions of dens invaginatus. This is the image you will see in most of your question banks also and in your question papers also. Right, you can see here. You know, first of all, what is dens invaginatus? We have infolding of enamel into the dentine. So most common form of dens invaginatus is this type 1 dens invaginatus, where you can see that infolding has not crossed the junction. The infolding has not crossed the junction. So you can see here, this is the most common type of dens invaginatus here. Type 1 type. That is the type 1. The second question which you must have encountered in that question bank also and in the previous years also, and that second question was that which of the developmental pathologies are related with periapical pathology, right? Which of the developmental anomaly can be a risk for the development of periapical pathology? और उसका एकदम clear cut answer is dens invaginatus. This dens invaginatus is important because that infolding which is present there, caries can develop, pulpal necrosis can develop, periapical infection can develop. Okay, so you can please note down this thing wherever you are writing your notes, that the developmental anomaly which is associated with periapical infection is dens invaginatus. Pulpal involvement takes place very fast here. Okay, and then this classification that is given here, that is Euler's classification. Now oral pathology people can teach this classification very well. I can only tell you as a radiologist perspective that dens invaginatus type 1 is when the infolding of enamel is in the dentine, the junction is not crossed yet, when proper pulp chamber is involved, and you can see that pulpal involvement is there. देखो widened chamber आपको दिख रहा है. This is type 2 dens invaginatus. And then there is a very deep form of dens invaginatus, very deep form, that is type 3. And remember students, as a radiologist, one question may come in your exam from the radiology point of view, that what is the deepest form? What is the deepest form of dens invaginatus called as? So anyone can answer that? Deepest form of dens invaginatus is called as. What shall be your answer? Deepest form of dens invaginatus is called as. I'm sure all of you by now, because अब तो वैसे भी time नहीं है, are going to answer this question very well. that deepest form of dense invaginatus is called as this? Anyone? See, I feel much better when I see you all. Abhi dekho aap log ko dekhkar and you are all good messages. When I see, I feel much better now. My voice is also improving with that, right? So I have got the answer from Dipesh. Yes. Please remember, students. Very good, Dipesh. The deepest form of dense invaginatus is called as dilated odontome. Exactly correct, Varsha. The deepest form of dense invaginatus is called as dilated odontome. Now this has nothing to do with that odontome what we discussed on Monday. Compound, complex, no, nothing to do with that odontome. Dilated odontome is the term used for deepest form of dense invaginatus. This you all have to remember, and I can see that everyone is answering, so you all are very well prepared with this question. Good. Talent cusp we have already discussed in the last class. Monday ko we had discussed this, so nothing very interesting for us from our point of view. So I will just skip this and I will show you another important question which I wish to show. And will ask from you only that what comes to your mind when you see these pictures. Now students, the pictures, the images which I am going to show you today, you all have seen these images. You all have seen these images many times in my revision classes. In my classes I have shown you these images. So quickly I am revising these images with you all pertaining to the questions that have come in previous years, that question bank which has been given to you, and so that you all can revise things correlating with the images by themselves, right? So students, tell me, when you see this IOPA or this radiograph, what is coming to your mind? What is coming to your mind when you see here? See, I am getting the answers very fast now. I use red color only. I am getting the answers very fine now. So देखो कितनी जल्दी you people are giving the answers. Yes, you are right. This is hyperparathyroidism. While I was going through the previous questions, students, I just realized one thing, that hyperparathyroidism pe lot many questions are there in your exams. Right? They have said that patient is having weak bones, but hypercalcemia is there. Answer is hyperparathyroidism. They have asked osteitis cystica fibrosa. Where do you see osteitis cystica fibrosa? The answer again is hyperparathyroidism. Right? So that is what I am telling, that you get lot of, yes, exactly Shivani. You get lots of questions on hyperparathyroidism. So how did you recognize that this is hyperparathyroidism? I am sure there is generalized loss of lamina dura. अगर आप यहाँ देखोगे, there is generalized loss of lamina dura. Right? Now in hyperparathyroidism, all the calcium from bone is carried into the blood. So serum calcium level is increasing, but the bones are becoming weak. So bones on radiograph, they appear dull. In contrast, the teeth, they appear not very bright. There is generalized loss of lamina dura, and when we check out the trabecular pattern is very granular. And when the trabecular pattern of bone is granular, we say that this is typical ground glass appearance. We call it as ground glass appearance. So, ground glass appearance most commonly is seen in fibrous dysplasia, but apart from fibrous dysplasia, it is also seen in hyperparathyroidism. Right? So, very well answered. Very well, you people have recognized this radiograph very nicely. Yes, this is a case of hyperparathyroidism. Correct. If I go to the next slide now, so that is the earliest change of hyperparathyroidism that we see, that there is subtle erosion of bone from the phalanges. What you notice here is there is subtle erosion of bones of, like आप देखिए आपका phalangeal bones जो हैं इनका erosion हो रहा है. This is the earliest change that is seen in hyperparathyroidism. Okay, and then this is what is osteitis cystica fibrosa. and this question has come already in your NEET exam. So please know what is osteitis cystica fibrosa. Please note, students, that osteitis cystica fibrosa is associated term with hyperparathyroidism when it involves the long bones. Because of decreased calcium levels, we have osteolytic areas in the bone. We have osteolytic areas in the bone. Now these osteolytic areas in the bone, they appear like cysts, but they are not cysts. They just appear like cysts because of osteolytic changes, osteoclastic activity, right? So such cyst-like areas in the long bones in the patient of hyperparathyroidism is called as osteitis cystica fibrosa. And similar false cystic areas we see in osteoarthritis also, and they are termed as, I'm sure all of you remember, they are called as Ellie cysts. So even these Ellie cysts are not true cysts, they are false cysts only, and they are again because of osteolytic activities, and these osteolytic cysts called as Ellie cysts are seen in TMJ osteoarthritis. So these दोनों terms you have to remember like this. Ellie cyst in osteoarthritis of TMJ, osteitis cystica fibrosa in hyperparathyroidism. Whatever I am telling you in hyperparathyroidism is sufficient. इतना बस today you remember, and that much is enough for you all. इससे ज़्यादा बाहर से वो कुछ कभी नहीं they are going to ask you, right? Even in hyperparathyroidism, we have some radiolucent areas onto the skull, but these radiolucent areas, देखो, these are not punched out radiolucencies what we see in multiple myeloma. However, they mimic like punched out radiolucencies that we see in multiple myeloma. Students, याद रखना, even if they will give you a picture like this and they ask you what is this, so please remember, just read down the options. Probably they are not asking hyperparathyroidism, probably they are asking multiple myeloma only, because punched out radiolucencies in multiple myeloma are common and one of the favorite questions of examiners. When such radiolucent areas are seen on the skull in the patients of hyperparathyroidism, we call it as salt and pepper appearance. Or sometimes called as pepper pot appearance. So salt and pepper appearance or pepper pot appearance is hyperparathyroidism. But then if they are showing salt and pepper appearance, they will give you hint in the question regarding hyperparathyroidism, right? If they are giving no hint, answer is multiple myeloma, because maximum cases mein punched out radiolucency also appears exactly similar, correct? Moreover, whenever they will give a question on multiple myeloma, you all know that if they will give a question on multiple myeloma, they will give you that hint that all these things are present in the bone and all those important tests which are related to multiple myeloma, that plasma cell malignancy will be very much mentioned then and there. Alright, so this much you remember, students. If they will give you a question on hyperparathyroidism, they will mention about hypercalcemia. Of course there will be hypercalcemia because calcium from bone has come to blood. Okay, they will mention about weak bones. They will mention about loss of lamina dura. They will mention about this ground glass appearance and a tumor which is present. And that tumor of hyperparathyroidism is called as Brown's tumor. This Brown's tumor of hyperparathyroidism, remember one very important thing. This Brown's tumor of hyperparathyroidism, it consists of giant cells. Histologically, you will have giant cells. So they will ask you histological correlation also, that you see a tumor in a patient who had hypercalcemia, and in that tumor you see giant cells. So please understand what they are asking. They are asking from you hyperparathyroidism, and even radiologically, I am sure all of my students know that this Brown's tumor of hyperparathyroidism radiologically resembles central giant cell granuloma. This Brown's tumor radiologically resembles central giant cell granuloma. So this is all about hyperparathyroidism. If you know these important points, none of the MCQ you can mark wrong. Not to worry at all. Alright. Switching on to the next question now. After hyperparathyroidism, I am opening that PPT now, and so that we can continue with the questions. So these were the questions. I had made the slides. So I will open the last slide and I will talk about this slide first. Okay. So another question that is present in your previous year's paper is this, and I'm sure it is not a difficult one, and you will immediately tell me the answer. Now tell me who's going to answer this question first. Very simple. A 45-year-old female complains of recurrent episodes of unilateral severe pain or severe headache which exacerbate with head movement, exposure to bright light and loud sounds. Now this female is suffering from, tell me what is the answer, students. So B1, okay. So Yasin and most of you are saying that the answer is migraine. Alright. And I am agreeing with this question that the answer is migraine. Now students, why I am discussing this question is that we should very much know the difference between migraine and cluster headache. Do not forget that even cluster headache is very important and one of the favorite question of examiners. You should know the difference between migraine and cluster headache. Migraine is common, students. Many of us suffer from migraine, right? And we have severe headache. One side of the head is involved. This pain radiates backward also. Even when you move the head, pain is there. Patient is not able to tolerate light, sounds, feeling of vomiting, discomfort is associated with migraine. We all know this, right? We all know this. On the other hand, if I talk about cluster headache, students, agar they wanted answer cluster headache from you, they would have said in this question that a 45-year-old female complains of unilateral severe pain around the eye. So even cluster headache is unilateral, undoubtedly, but the pain of migraine is unilateral on the forehead migrating to the head. But the pain of cluster headache is unilateral, but it is localized around the eye. So if the patient is saying that the pain is around the eye, it is cluster headache and not migraine. It is cluster headache. Okay. And even cluster headache is also, it's a very severe kind of pain. But one thing about cluster headache is that it lasts little shorter as compared to migraine. Migraine can last for 6 hours, 8 hours, sometimes a full night a patient is having pain. But cluster headache is for 1 hour, 1.5 hours or 2 hours. Itna rahega, then the periods of remission will be there. Another important point about cluster headache is that it occurs every day at the same time. This cluster headache every day occurs at the same time. That is why cluster headache is also called as alarm clock headache. That is why this cluster headache is also called as alarm clock headache. Even cluster headache is also called as a neuralgia. And which neuralgia, student? Again a previous year's question. Cluster headache is also called, yes, as one neuralgia. What neuralgia is cluster headache? Previous years mein 2 baar we have got this question that cluster headache is also called as this neuralgia. And what is that neuralgia? Yes, Shweta, it is very well called as alarm clock headache. But apart from that, it is also called as, yes, it is also called as, very good, you all are aware of it. It is called as sphenopalatine neuralgia. Now these are again important questions, students. It is also called as sphenopalatine neuralgia. Sphenopalatine neuralgia. And you know, sometimes one syndrome is associated with cluster headache. Or in fact, हम बोल देते हैं that cluster headache is present in this syndrome which starts from H. Now, Khushi, you are way ahead. Very good, Khushi. So, Khushi has already answered what I was going to ask. The syndrome, if someone says associated with cluster headache, your answer has to be Horton syndrome. Exactly. Your answer has to be Horton syndrome. If someone asks you syndrome associated with cluster headache, immediate answer which should come in your mind is Horton syndrome. Now, Horner syndrome is different and Horton syndrome is different. Horner syndrome is when there is ptosis, meiosis, anhidrosis, right? So that is Horner's. What different है? Horton syndrome, if someone is asking, the answer is cluster headache, sphenopalatine neuralgia. I stand by my words that you all are very nicely prepared with the subjects like oral medicine and oral pathology. You have to focus on general medicine, general surgery, public health dentistry, biochemistry, dental materials and pharmacology. These will give you ranks. Okay, देखो अपनी हालत. You people are so nicely prepared. So nicely prepared. Right? You all are doing it so well. And your mission for getting a good rank in the upcoming NEET exam will be fulfilled 100% the way you are answering, the way you are working hard. Very good. Yasin, I understand prostho is hard and even you get lot many questions in prostho also. DM, prostho are correlated questions you will get. So even prostho you need to revise very nicely. I still remember when I used to give my exam, so we had All India exam different and UP PG exam different. So UP PG mein Yasin, they used to ask so many questions in prostho. Lots of questions even prostho say you should be knowing. Prostho is not hard. Please make on dental materials as well, sir. Achha. I didn't understand the thing, but okay. So prostho is not hard. Prostho, when you will sit there, you will get the answer. Prostho, you will get all clinical questions. So that you will answer then and there. Trust me. Right? Okay. Coming on to the next question. So this is very nice. You have answered all the things very nicely. And now, I'm sure orofacial pain clear है. एक question और बता दो बस cluster headache से related, and that is if there is an acute episode of cluster headache. Acute episode means patient का वो जो short lasting pain होता है वो एकदम से हो रहा है बहुत जोर से and patient is very much in discomfort. So if there is acute episode of cluster headache, how will you abort it? How will you abort the acute episode of cluster headache? We know that we have ergotamines, we know that we are giving even calcium channel blockers, हम ये सब दे रहे हैं, we know this, but that is okay. We are giving prophylactically. All these drugs are giving prophylactically so that patient does not develop this pain. But if the pain is there, so acute abort of that pain is done by, and yes, the answer is correct. The answer is oxygen. You immediately have to give oxygen to the patient. That oxygen will relieve that hypoxia developed, yes, and then patient will feel better with oxygen. Correct? So these are the few questions which you have got in previous years, and this time also you may get, and you are not going to make any mistake. All right? Now this question is very bad. I saw this question in the question bank and I was very unhappy with the question. The question is, xerostomia is seen in all except hypertension, old age, Sjogren syndrome, diabetes. Now according to me as an oral medicine person, I feel that xerostomia is seen in all these conditions. You can try Yasin oxygen and TN also, but when we come to MCQ point of view, so we usually oxygen with this thing. Trigeminal neuralgia, we don't use the term. We will again be focused on carbamazepine. We have to be very specific, Yasin. Okay. So you all are answering it A. See, okay, you all are answering is A, I agreed. But then as a teacher or as a doctor, I still not agree, because even I believe and I have seen with my own eyes that antihypertensives, when a patient is of hypertension, definitely the patient is taking antihypertensives, and even these antihypertensives, they lead to xerostomia. All the heart patients who are subjected to either angioplasty, angiography, cardiac pacemaker surgeries, or whatever, this thing, bypass surgeries, they are giving a lot of drugs. The blood pressure needs to be controlled. To control the blood pressure, many times diuretics are also given, and these diuretics and other antihypertensive drugs, they very much lead to xerostomia. So, but they have not mentioned antihypertensive drugs. That is okay. But if I relate, so I will say that why even they have hypertension. If patient is there, so must be patient is on antihypertensive. So a patient should have xerostomia. Old age, so definitely salivary function reduces. So in old age, xerostomia is there. Sjogren syndrome, so definitely is related with xerostomia, and even diabetes is related with xerostomia. Even patients with diabetes, they have xerostomia, plus anti-diabetic drugs, they also lead to xerostomia. So for me, all the 4 options are correct. But then we have to choose the best out of 4 now. When such MCQ comes, we need to select the best out of 4. So best will be hypertension only, because they have not mentioned about anti-hypertensive drugs. Hypertension in itself will not lead to xerostomia unless antihypertensives is given. Diabetes can itself lead to xerostomia. So we have to choose the best answer. That is why we are choosing hypertension. But then I am not very happy with this question. This is not a very well made question. But then we have to learn these questions. हम बच नहीं सकते in questions, isn't it? You will get many such questions in your exam. Next is, all radiographic techniques are used to detect zygomatic fracture except. अगर आप लोग को याद हो, so this question I had discussed with you when I was teaching you external imaging. Right? I had discussed you this question. Now this question was very much confusing when it came in the NEET exam. I think it came last year or last to last year. And this question is, all radiographic techniques can detect zygomatic fracture except. Can detect zygomatic fracture except. Right? Now, most of the people answered OPG. Some of you answered Waters. But then students, हमें ना बिल्कुल ये जितने भी anatomical landmarks what we see in these extraoral radiographs, that also we should remember. If I talk about OPG, why? In OPG we see zygomatic arch, we see zygoma also. So why not in OPG? Not very clearly, but we can get a hint of zygomatic fracture. Right? Many times in OPG we can say that zygomatic fracture is present. Waters view to one of the best view for zygoma fracture, and even we can see zygomatic arch in Waters view. So this is also right. This is also right. Submental vertex, so definitely submental vertex and its modification, jug handle view, they are the best views for zygomatic arch fracture. So kaun sa bacha? The answer is reverse Townes view. Now this reverse Townes view, it shows you the condylar neck fracture. It shows you the condylar neck fracture. We are more focused on condylar neck region when we open the mouth. So in reverse Townes, we are not able to see any zygomatic area. Right? So the best answer here is reverse Townes view. This will not detect zygomatic fracture. Right? OPG is one of the best screening view. OPG is one of the best screening view for many fractures, condylar fractures, neck fracture, ramus fracture, symphysial fractures, parasymphysial fractures. Best दिखते हैं OPG में, right? And even I will say that mandibular fractures are best seen. Mandibular fractures are best seen in OPG. If OPG is not in the option, then remember that mandibular fractures are best seen in lateral oblique projection. If OPG is not there in the option, then remember students, all mandibular fractures are best seen in lateral oblique view. Now this lateral oblique view is of two types: lateral oblique ramus projection, lateral oblique body projection, right? So they are best to visualize the body and the ramus fractures. Which one? Lateral oblique. But when you have to choose between OPG and lateral oblique, I think RP group mein I sent you that information, that when you have to compare both, then please remember lateral oblique will come always second to OPG. OPG will be the best view. Now lateral oblique was mainly taken when OPG was not there. Now with the advent of, because OPG is there, we are exactly both horizontal and all fractures we are best seeing in OPG. If OPG is not there, then the answer will be lateral oblique. I repeat students, one of the other conventional radiography, after 20, around 18 days almost, you people will be giving your NEET exam, for which you've been preparing since so long. Many of you might be, थोड़े से discouraged also, but then don't be discouraged. Keep yourself confident enough that so to fold kari aana hai is exam ko, because you've been working hard for this exam, right? But then in your exam, on upcoming exam, you will have one or the other question on these radiographic projections. One or the other question on these radiographic projections. Ruko, good slide to revise you these radiographic projections. एक question तो आपको इनमें से जरूर मिलना है, and I am 100% sure about it. So quickly, I am revising for all of you. Quickly, I am revising for all of you the questions which you may get in your NEET exam. So best view for zygomatic arch fracture. I'll choose the ink. I'll just change the ink color. Wait. Color shall be black. Okay. So best view for zygomatic arch fracture will be jug handle view anytime. If jug handle view is not in the option, then your answer will be submento vertex. Jug handle view is the best answer, but then if jug handle view is not in the option, then second best view will be your submento vertex view. Remember students, when we reduce the exposure to 1/3, then we see this jug handle view where the zygomatic arches are seen as the handle of jug. Alright. Base of the skull is best seen in submento vertex view. If we have to see the base of the skull, it is best seen in submento vertex view. Zygoma fracture. I am not talking about zygomatic arch. We are talking about zygoma. So zygoma fracture are best seen in Waters view. You all know this now. Correct? Paranasal sinuses are best seen in Waters view. Right? Khaskar frontal sinus, maxillary sinus, ethmoidal sinus. These three sinuses are very well visualized in Waters view. But yes, if you want to see this sphenoidal sinus, we need to take this Waters view in the open mouth position. Also, you can see sphenoidal sinus in submento vertex view, because there you see the base of the skull. Correct? So even sphenoidal sinus can be seen in submento vertex view. Alright, so I am sure you all are very well versed with these radiographs. Correct? Nasal septum. Now nasal septum, the bony nasal septum, because we take Waters view like this. So yes, nasal septum is again best seen in Waters view. Nasal septum is again best seen in Waters view. Condylar neck fracture, that is high condylar neck fracture. Actual condylar neck fracture is high condylar neck fracture, and it is best seen in reverse towns. High condylar neck fracture is best seen in reverse towns. However, low condylar neck fractures are best seen in PA view. Low condylar neck fracture are best seen in PA view. Coronoid process fracture. If coronoid process also they are asking, again your answer will be Waters view. Actually it is called as PA Waters. For coronoid process fracture, the best view is PA Waters view. Yes, very good. The most of you are answering it. Very nice. Again, fracture of ramus and body, OPG is the best answer, and after OPG we have lateral oblique. For fracture of ramus and body, OPG first, then lateral oblique. Nasal fractures, ये बताओ. Now ये बताओ मुझे, nasal fractures are best seen in. Let me see how many of you remember. In old literature ये question बहुत बार आया है. Nasal fractures are best seen in. हम ऐसे लेते हैं nasal fractures. So nasal fractures are best seen in which view? Nasal fractures are best seen. Yes, not lateral ceph. Not lateral ceph. Nasal fractures are best seen in lateral skull. As an oral medicine person, I'll never mention ceph. Okay. So nasal fractures are best seen in lateral skull. Very good. All maxillary fractures, be it Leaford 1, 2, 3, Campbell lines, Trapnell lines, elephant lines. Remember all these things? Elephant lines, so 3 line हमने जो बताई थी. And then all those Campbell line, the last lowermost Trapnell line running around the along the lower border of mandible from one ramus to other. All these are seen in Waters view. All these maxillary fractures, these lines are beautifully seen in Waters view. Exactly. And all these appearances, copper beaten appearance in Krausen syndrome. If you remember tram track appearance like this, tram track calcifications or tram line calcifications, right? All this was seen, all these are seen in lateral skull. All these are seen in lateral skull, right? Tram track appearance or tram line calcifications are seen in Sturge-Weber syndrome. Copper beaten appearance is mainly seen in Krausen syndrome. Hair on end appearance is mainly seen in thalassemia but also seen in sickle cell anemia. Is mainly seen in thalassemia but also seen in sickle cell anemia. Remember students, if they are asking hair on end appearance and they are saying that this hair on end appearance is seen in blacks. So when racial predilection comes, so they are expecting answer sickle cell anemia from you. If racial predilection they are asking that it is seen in blacks, then your answer will be sickle cell anemia. If they are not mentioning anything about racial predilection, they are expecting answer thalassemia from you, because hair on end appearance is best seen in thalassemia then sickle cell anemia. So these are the ways, yes, by which you should remember these things, right? So how quickly we are revising these important. इनमें से एक नया क्वेश्चन पेपर बन चुका है आप लोग का, और एक नया क्वेश्चन is there definitely, right? And when we talk about our TMJ views, then you all know that lateral view of TMJ, the ankylosis, whatever we see, is best seen in transcranial projection. So transcranial projection, it shows us the lateral view of TMJ. When we talk about the medial view of TMJ, then the best view is transpharyngeal projection. So transpharyngeal projection shows you the medial view of TMJ as well as the osteoarthritic changes. And when you need to see condylar neck fracture, so skull view best is when you have to when condylar neck fracture is to be checked. So best skull view is lateral skull. But if they are asking the best TMJ view, then best TMJ view for condylar neck fracture is transorbital. Best TMJ view for condylar neck fracture is transorbital. If they ask you internal disc dearrangements are best seen in, so you know that MRI is for soft tissues and disc is a soft tissue. So internal disc dearrangements, that disc reduction with or without reduction, is best seen in MRI. Is best seen in MRI. But when it is about bony ankylosis and all those things, so bony changes are best seen in CT scan. Bony changes are best seen in CT scan. Another one important question you must have noticed in your previous year's papers regarding MRI, that pathologies are best seen in which MRI? We have two types of MRI. Remember, T1 weighted images in MRI and we have T2 weighted images in MRI. Remember, T1 weighted images are fat images, T2 weighted images, water images. T1 weighted images, they show the normal anatomical structure. And where do you see the pathologies? This question is again there, students. When you see those previous year question bank, this question is very much there, that in MRI, if you need to see pathologies, you will take which image, T1 weighted or T2 weighted? Yes, so you all are answering correct, that for pathologies we go for T2 weighted images, that are fat images. In T1 weighted images, we see the normal anatomical landmarks, and in T2 weighted images, we see the pathologies. Correct. Bony ankylosis best seen in CT, CBCT, but when it comes to fibrous ankylosis, actually fibrous ankylosis also you can see in CT, CBCT, but then MRI would be better. Disc perforations are best seen in arthrography. Again an old question. Disc perforations are best seen in TMJ arthrography. If you want to see the disc perforation, arthrography, TMJ arthrography will be your best answer. Exactly, students. Okay, so this is one thing. Coming back to the questions part where we were discussing conventional radiographic images, and I am always very sure of that one or the other question you will get from these conventional radiographic techniques. Kahin na kahin 100% you will see such a question. And while going through that question, I found one more question on lacrimation on eating. Now students, there are two things. One is sweating on eating. One thing is called as sweating on eating. And one thing is called as lacrimation on eating. So sweating on eating is because of which nerve? And lacrimation on eating is because of which nerve? So you all are correct, students, that sweating on eating is a part of Frey syndrome, Frey syndrome, and sweating on the forehead while we eat. So the nerve involved is auriculotemporal nerve. The nerve involved is auriculotemporal nerve. That is your Frey syndrome. But remember, all of you, that lacrimation is different, sweating is different. Sweating on eating is Frey syndrome, auriculotemporal nerve. But when we are talking about lacrimation on eating, that is called as crocodile tears. Yes, that is called as crocodile tears. So these tears occur because of facial nerve. Yes. So lacrimation on eating, if someone is having, it is because of involvement of facial nerve. But if sweating on eating they are asking, it is because of involvement of auriculotemporal nerve. So these are two different things. These are two different things which you should be knowing and never getting confused. Lacrimation on eating and sweating on eating. Lacrimation on eating is facial nerve. Sweating on eating is auriculotemporal nerve. Yes, very well answered. Megha is asking, what is the difference between MRI and ultrasound? In some surgery questions we have to choose USG. So how to know when to choose USG and when to choose MRI? बहुत ध्यान से सुनो students. MRI is gold standard. MRI is gold standard. So whenever you have to choose between ultrasound and MRI, Mostly we choose MRI because MRI is standard. However, MRI is expensive, so most of the time हम ultrasound से काम चलाते हैं. But ultrasound is a real-time imaging modality which is based on observer's perception. It is based on observer's perception. In MRI, you are seeing lot of images. In MRI, you are seeing lots and lots of images. That means in MRI, आप देखते हो proper anatomical landmark also, different sections, different levels, and your diagnosis is more perfect. So most of the times, surgeons, they expect the answer MRI. But, now this but is very important. When it comes to salivary glands, then the answer preferred is ultrasound. Tumors of salivary gland, then MRI. But when it comes to salivary gland disorders, then the answer will be ultrasound. If they are asking about fine needle aspiration cytology, so fine needle aspiration cytology nowadays is done ultrasound guided. So then the answer will be ultrasound. When they are talking about vascular abnormalities, then they will expect answer as ultrasound. So this is how you have to choose your answer. Yes, for parotid, that's what I'm telling. For salivary glands, choose answer as ultrasound. It is one of the best technique for salivary glands. Alright. So this is important and this is what you have to remember. Then one question which I saw students, now these are the questions which we are discussing and the answers which you have must revise before exam. So these are the questions and I found, I'll just show you a picture, many questions on OKC, that is basal cell nevus syndrome, many questions on basal cell nevus syndrome and also many questions on ameloblastoma. We are getting a lot of questions on ameloblastoma also. I'll show you the images where ameloblastoma is there. See, like this. Can you see here? They are showing lot of buccolingual expansion of cortical plates and then they are asking the question that buccolingual expansion of cortical plates most commonly seen in, and the answer is definitely ameloblastoma, because in OKC we do not have buccolingual expansion, but what do we have? We have anterior-posterior. Expansion. It expands anterior-posteriorly, right? So, lot many questions. Even last year, we had one question on ameloblastoma. Last year, again, we had a lot of questions on ameloblastoma. So, while going through these papers, I realized ameloblastoma, CG, even we had questions on central giant cell granuloma, hyperparathyroidism, then OKC, one question on dentigerous cyst, on adenomatoid odontogenic tumor, myxoma मैंने बहुत नहीं देखा questions में, but ये questions which I have just taken the name, है ना, ये these questions I have seen in many times in your NEET exams question bank. Okay, so quickly let us revise these lesions. एक question bank की demand मेरे पास बहुत ही time से आ रही है, the demand of this question bank, that please send that question back in a PDF format. But students, you don't have to revise all those things. सब कुछ you have revised. Everything is there in your brain. You don't need this question bank. Now it is all done. Trust me. All these image-based questions, pathologies, radiological pathologies, which you will see in your NEET exam after a few days, all of you are going to answer it very well, right? But quickly, I am revising with you. Fatafat dekho, and I will be little bit faster, students, because the time is, I don't have to take a lot of time for you all. So I will just show you some important things and then we'll fatafat se bhago fai aage. So opening one important PPT which is must know for all of you. So students, these are two OPGs and I'm showing these OPGs not to tell you any pathology. Jyoti is asking, sir, please quickly differentiate between peripheral giant cell granuloma and CGCG. And then how to differentiate between OKC, Univ cystic ameloblastoma in OPG. I'm coming to all these things. Right? But for simple answer to Jyoti is, Jyoti, central giant cell granuloma, wherever central term comes, that means that the lesion is present within the bone. So central giant cell granuloma is present within the bone in the anterior mandibular region, can cross midline, okay, and it has got that wispy septa, degenerating granular septa. PCGC, that is your peripheral giant cell granuloma. When peripheral term is there, that means it's a gingival lesion. It becomes a soft tissue lesion. So peripheral giant cell granuloma, it is seen on gingiva. It is pinkish in color. When we take a radiograph of that region, we see that cupping bone resorption, that peripheral cuffing of bone or cupping bone resorption. Little bit bone resorption, that's it. Nothing else is seen because it is not a central lesion. It is a peripheral lesion. So peripheral giant cell granuloma will be a large exophytic lesion having a stalk or a peduncle. It will be a growth on the gingiva which will be pinkish. Right? The most important differential diagnosis of peripheral giant cell granuloma is pyogenic granuloma, which is seen mostly in the maxillary anterior region. And this pyogenic granuloma, how do we differentiate? Pyogenic granuloma is more reddish. Peripheral giant cell granuloma will be more pinkish. Moreover, pyogenic granuloma will not be having any radiographic changes. But peripheral giant cell granuloma, as I told you, have radiographic changes, and that is there will be cupping bone resorption, peripheral cuffing of bone. Okay. Coming on to the differentiation between OKC and unicystic ameloblastoma. Now, unicystic ameloblastoma is usually develops from the cystic lining of dentigerous cyst. So, it will be usually with an impacted teeth, attaching at CJ, but will be more aggressive. OKC, they will less likely they will show you with an impacted teeth because OKC is more common and is not very commonly associated with impacted teeth, and they will not like to confuse you. Okay. Coming on to the anatomic landmarks, I am not Nidhi. Yes, pyogenic granuloma is pregnancy tumor. You are correct, right? Someone is asking, how do you know that our paper is formed? Because I have not made any paper because बनी क्या होगा अभी नहीं वो papers तो बहुत पहले बन जाते हैं तो इसलिए that's why I am saying ऐसा कैसे हो सकता है your paper 20 days after 20 days and the paper is not yet made, so that is why I was saying. Okay, so coming on to the important thing, you know that last time we had a question on anatomical landmark and they had asked this very simple landmark, that is this. What is this landmark, students? ये आया था आपके NEET exam में. Which landmark is this? What landmark have I marked? Again, in previous year's paper, you have this image and this landmark what they have asked. So what landmark is this? What landmark is this? I think मुझे refresh करना पड़ेगा क्या? It has already been refreshed. So, what is present between the yes, so sigmoid notch, exactly, sigmoid notch they had asked. Sigmoid notch they had asked in your NEET exam. Right? But I still believe there are very, very important anatomical landmarks that we should know and that they usually ask, right? When we talk about maxillary anterior region, so we know in maxillary anterior region we have intermaxillary suture, the spine, the nasal septum, floor of nasal fossa, and when we come towards the canine region, so canine के ऊपर हमारा inverted Y line of NS is present. You remember above maxillary canine we have inverted Y line of NS. Many times they are asked. This question is asked. It is found above the maxillary canine and is formed by the intersection of floor of nasal fossa and floor of maxillary sinus. Right? Then important mandibular landmarks, you know, that behind the third molar we have external oblique ridge. Sometimes just onto the roots we have mylohyoid ridge. This is submandibular gland fossa. This is submandibular gland fossa here. We have inferior alveolar canal. Below the premolars we have mental foramen, which can only be seen radiologically. Question आया था, which of the following can only be seen radiologically? And the answer was mental foramen, which is present between below the roots of premolars, mandibular premolars. So these important landmarks, so I am sure you all know. But मैं हर बार बोलता हूँ, this stercomaxillary fissure is a very important landmark. And the stercomaxillary fissure, it is formed just when we go to the posterior wall of maxillary sinus. Right? So just behind the posterior wall of maxillary sinus, we have the stercomaxillary fissure. And students, why this is important? That whenever pathology is present, whenever pathology is present, this stercomaxillary fissure is obliterated. मैं अभी आपको दिखाता हूँ, चालू दिखाता हूँ. This stercomaxillary fissure is obliterated, and if this stercomaxillary fissure is obliterated, it suggests that a pathology is present. Now you see very carefully, students, this is stercomaxillary fissure, but it is obliterated here. Can you trace the stercomaxillary fissure in this OPG? No, I cannot trace it. तो अगर आपने ऐसे ही OPG देखा होता तो मुझे पूरा यकीन है कि आप लोग को बिल्कुल से नहीं रियलाइज होता कि यहाँ पे कोई पैथोलॉजी है. बट अब अगर आप इस तरफ देखो ध्यान से, इस तरफ देखो ध्यान से, और इस तरफ देखो ध्यान से, so tell me which side is the pathology? Is it on the right side or is it on the left side? Left side. Can you trace the stercomaxillary fissure on the left side? And can you trace the stercomaxillary fissure on the right side of maxilla? Now you check carefully. You will realize that a pathology is present. But when you are trying to trace the stercomaxillary fissure on the left side, I can trace it, students. देखो ध्यान से अब. This is your stercomaxillary fissure, but here it is traceable. You can still trace it. But can you trace it here clearly? Can you trace it here clearly? No. No. So how many of you say that think that the pathology is on the left side, and how many of you think that the pathology is on the right side? So you are getting confused. That is what I am telling you, students. Why these anatomic landmarks are important. Why these anatomic landmarks is important. These anatomic landmarks are important because they sometimes tell us regarding the pathology. So sometimes we always think, यार stercomaxillary fissure ठीक से trace नहीं हो पा रहा है, तो इसका मतलब कुछ problem है, कुछ pathology है. Stercomaxillary fissure is obliterated, so pathology है. So you see the right side, students. It is on the right side that we cannot properly trace the stercomaxillary fissure. I agree with you. Left side में भी बहुत अच्छे से trace नहीं हो पा रहा है, but right side पे तो बिल्कुल obliterated है. Right side में it is completely obliterated, and we have fibrous dysplasia on right side. If we see carefully, we have fibrous dysplasia on right side. On right side we have, I'm removing the ink, all ink things. If you see carefully on the right side now, the trabeculae, they are granular, and we have characteristic ground glass appearance on the right side. We have characteristic ground glass appearance on the right side. So this is a case of fibrous dysplasia, diagnosed only with the help because of stercomaxillary fissure. So I can easily confuse you, students. मैं आपको left side दिखा के confuse कर सकता हूँ, but then you have to be very careful as a doctor, क्योंकि अब टाइम आ गया है आप लोग का कि आप डॉक्टर्स हैं. You have to diagnose it. You cannot miss the pathology. So that is why I always tell that stercomaxillary fissure is a very, very important landmark, students. Right? So, shadows. You remember these shadows? I have shown you these shadows that we have radiographic shadows on OPG. Remember? We have palatoglossal air space, nasopharyngeal air space, and glossopharyngeal air space. I have shown all these things, students. If you see in this region, this is palatoglossal air space. यहाँ पे present है आपका ये जो पूरा आप देख रहे हो, this is nasopharyngeal air space. And what is crossing the mandible? It looks like fracture lines are there. देखो bilateral when you see the ramus region, it looks like as if fracture lines are there. But these are not fracture lines on the ramus. These are not fracture lines on the ramus. These are air spaces, students. These are air spaces. And these air spaces which are seen on the ramus of mandible, ऐसे cross करती हुई, these are glossopharyngeal air spaces. These are glossopharyngeal air spaces, again normal. Glossopharyngeal air spaces are again normal. Right? I am showing you, students. I am repeating it so that you don't get confused. What you see here is your palatoglossal air space. यहाँ पे जो आपको radiolucence एक बार दिख रही है, you sometimes they mimic it pathology, but this is an air space. Now I had a very good diagram, but it is not. I cannot show you here, where you see that this is palatoglossal air space. Here, where the neck of the condyle is there, the radiolucency which is crossing the neck of the condyle. Right, this is your nasopharyngeal air space. So 2 is your nasopharyngeal air space, palatoglossal air space and nasopharyngeal air space. And this region जो आप पूरा देख पा रहे हो, this region जो आप radiolucent देख पा रहे हो, now this is your glossopharyngeal air space. This is the glossopharyngeal air space. Glossopharyngeal air space. So these are 3 important air spaces: palatoglossal, nasopharyngeal and glossopharyngeal. And even this region जो होता है, इसमें you see the tongue shadow also. इस region पे clearly you see the tongue shadow also. I think I will अभी let me go ahead. Yeah, I will show you अभी just now. मैं आपको और clear दिखाता हूँ so that you are confused more. I have opened this slide also and I'll show you on this slide. Wait. आज मैंने पूरा पिटारा अपना खोला हुआ है so that all of you can see this and don't get confused. So this was that image of pterygomaxillary fissure coming down. Yes, when we come down, students, then आप ध्यान से देखो. Can you see the landmarks here? Can you see the tongue shadow here in this region? Tongue shadow. If they have drawn here also tongue shadow. So very thin tongue shadow. In every OPG you see tongue shadow. In some OPGs it is very peculiarly seen. In some OPGs it is not very peculiarly seen. So बस ये यहाँ इस region में you also see, as I was telling you, tongue shadow. Can you see here? Tongue shadow. This is your hard palate. यहाँ पे आप ध्यान से देखोगे, you will see presence of hard palate. Now when we talk about the shadows, so I will show you the shadows here. Now you see the shadows clearly and you will understand it nicely, students. So this is your palatoglossal air space, that radiolucent area which I was talking about. So this is your palatoglossal air space. Number 2, crossing the neck of the condyle. देखो ये region में जो number 2 देख रहे हो, this is your nasopharyngeal air space. This is your nasopharyngeal air space. और ये जो number 3 ऐसे ramus को cross करता हुआ आ रहा है shadow. Can you see here? Crossing the ramus of mandible. What you see here is your glossopharyngeal air space, which is crossing the ramus is your glossopharyngeal air space. So these are the 3 important air space which can mimic pathologies, but they actually are not pathologies. And that you can see on these slides. Alright? Now you can see all these spaces. देखो वही figure फिर से आ गई. This is your palatoglossal, this is your nasopharyngeal, and this whole region what you see is the glossopharyngeal air space. और यहाँ पे ये जो आप glossopharyngeal air space पूरी देख रहे हो, इधर हल्का सा कई बार tongue shadow भी clearly दिखती है. With experience you will see all those things. With experience you will see all these things. Right? Now I am coming back to the slides so that हम फटाफट इसको cover कर सकें, because again then class will go very long. I'll just switch on the slides and show you the slide. Now students, just check out the trabecular patterns. Just check out the trabecular patterns. If you see here, now on this slide I am talking about the trabecular pattern. We all know that in posterior mandible, the trabecular pattern, they are different. That means the marrow spaces are large, and trabecular pattern, they appear as if they are put one above the another, giving that characteristic step ladder appearance. You know this, that characteristic step ladder appearance is seen in normal posterior mandibular region. And all of you should know this, that one question is asked in the previous year's papers, which is there, and that question is, what is the first change that you see? What is the first change that you see whenever any pathology is there? So remember students, first change what we notice in trabecular pattern is there is blurring of trabecular pattern. There is blurring of trabecular pattern. That is the actually first change of initiation of a pathology. First change usually of initiation of a pathology. और भी याद रखो students, even in thalassemia, sometimes we see blurring of trabeculae. देखो normal trabeculae अलग होते हैं, and sometimes in thalassemia also we notice blurred trabeculae. And of course in your fibrous dysplasia, we know that the trabeculae, they become so small and granular that they give typical ground glass appearance. So little bit trabecular changes you should know, right? Going further, I'll just show you important things. So this is one slide which quickly let us revise. All developmental anomalies are there which are important, which is must know for all of you. Students, see carefully. Here you see fusion. You can clearly see fusion. So one very important developmental anomaly that you might see in patients is fusion. Gemination is different from fusion. Gemination is an attempt to divide into two halves, isn't it? Attempt to divide into two halves. So this is fusion when two crowns are fused. This is gemination. The crown is dividing into two halves. So this is gemination. This picture I have already shown, that is dense invaginatus, infolding of enamel into the dentine. So this is dense invaginatus. Dialaceration, you all know, lateral bending of root is dialaceration. And this also you know that sometimes if there is bucco or lingual dialaceration, when bucco or lingual dialaceration is there, we can see the presence of apical foramen. और जब हम ये apical foramen देख पाते हैं, इसको हम बोलते हैं bullseye appearance. We call it as bullseye appearance on the radiograph. All of you are aware of this. I don't know, because of me you are able to see taurodontism or not, but taurodontism भी आप जानते हो that in taurodontism it's bull's like tooth, bull tooth होता है. Crown is very bulky as compared to root. Crown is bulky as compared to root. So Yatendra is asking to show dense invaginatus types 1, 2 and 3. I think in the initiation of the lecture I showed it, right? मैंने आपको दिखाया था. So I will send you the pictures then, right? I will send you the pictures then. So these are important developmental anomalies, right, which you see onto the radiograph. This is all right. I will just go ahead and show you the important slides because time is less. Already it is 8:19. Okay. I hope you all are aware of cervical burnout and mag band effect. You may get a question on cervical burnout and mag band effect. You all should know that cervical burnout is an actual phenomena which is seen in the cervical region of normal teeth. And this cervical burnout is due to decreased absorption of X-rays. This cervical burnout is due to decreased absorption of X-rays in the cervical region of normal teeth. On the other hand, मैक बैंड इफेक्ट इज अ ऑप्टिकल इल्यूजन, जो आप यहाँ ऑप्टिकल इल्यूजन देख पा रहे हो ना बीच में. इफ यू सी carefully on those black boxes, so between these black boxes you will see grayish areas, right? Now that is MAC band effect. So sometimes on dentino-enamel junction. Now cervical burnout was seen at CJ, which was an actual phenomena. MAC band effect is seen on dentino-enamel junction, which is an optical illusion where our eyes perceive that at dentino-enamel junction caries is present, but actually it is not there. That is the perceiving whether our eyes is perceiving that. All right. So very important. Both cervical burnout and MAC band effect are very important, and you all that you should be knowing it. Okay. Going ahead, I am just quickly showing you some lesions which you should be knowing, because it is important to know the differences. Just a second. I think this is so heavy that it can disturb the proceedings. Anyways, I will again open it. I'll open this PPT and show you. Kushi, processing defects also okay, I'll try to discuss, but then we have little bit time and I have to discuss more, but I will try. तो मेरी एक सोती भी फोटो भी आप लोग को दिख रही है. Someone has clicked my photo where I am sleeping so nicely, and I have opened my folder and you can see that funny picture of mine also. क्या कितना देखो कितना फनी हमारे साथ होता रहता है जब हम ऑनलाइन यूट्यूब पे लाइव क्लास ले रहे हैं और आपकी इतनी फनी पिक्चर्स आप देख पा रहे हैं. वेरी नाइस, नो प्रॉब्लम. If I come here, so I will show you these slides which are very important. Thank you so much. I will try, but then again time का थोड़ा सा ध्यान रखना पड़ेगा, and then only I can continue. Okay, so how many of you, I mean I'm not asking now, because if I'll ask you, फिर again the time will be more. So I am not asking, only I am telling you the answers now, right? Only I am telling you the answers now. So what you see here, thank you so much for your kind words. You people are too kind to say all these things, but thank you. So what you see here, students, that teeth is vital. All the teeth are vital, but still you have some lesions present. So you all know that this is PCOD. What we see on this slide is periapical cemento-osseous dysplasia. This periapical cemento-osseous dysplasia is also called as cementoma, and it is always associated with vital teeth. It is always associated with vital teeth, and most common site, it is associated with mandibular anterior teeth. Most common site is that it is associated with mandibular anterior teeth, right? So whenever there will be a question on PCOD, mandibular anterior teeth, vital teeth, multifocal involvement, all the mandibular anteriors are involved, multifocal involvement is there, and teeth are always vital. And if you remember, I told you in its initial stage it is completely radiolucent, then become mixed, and then in the mature stage this lesion is completely radio opaque. Very important question on PCOD you may get in your NEET exam. Okay, remember all these points which are important. Correct? You all know a cyst which is seen associated with the lateral surface of the root is lateral periodontal cyst. This lateral periodontal cyst is attached with the lateral border of the root, and it has a variant. Sometimes this lateral periodontal cyst can appear multilocular, resembling grapes, bunch of grapes, and this variant of lateral periodontal cyst is termed as botryoid odontogenic cyst. So botryoid odontogenic cyst is a variant of LPC, lateral periodontal cyst, which resembles bunch of grapes or multilocular. Okay. Whenever you see an image and you see a cyst just below the inferior alveolar nerve canal, I am sure that you all know that this is not a cyst, it is just resembling a cyst. This is not a cyst, it is just resembling a cyst. However, it is called as Staphne bone cyst. However, it is called as Staphne bone cyst. So please remember, all of you students, that Staphne bone cyst is not a true cyst. It's a false cyst. Again, I think load मैंने ज़्यादा PPT खोल रखे हैं. Wait, just take a break of 1 minute, students. Let me open the PPT so that we can just read it nicely. Just give me a minute, huh? Okay. Okay, so that 1 minute is over and I am back because time का हमें देख के चलना पड़ेगा and I have opened this PPT. इस पे देखते हैं आराम से हम लोग and I'm sure अभी PPT चलेगा. So students, when I am talking about these lesions, the Staphne bone cyst, so I was about to tell you that Staphne bone cyst is basically not a cyst, it is just a lingual salivary gland depression, right? So when we talk about the principles of radiographic interpretation, we should very well see where the area, the pathology is arising from. So by epicenter we mean that where the pathology is originating. If the pathology is above the inferior alveolar nerve canal, it is odontogenic in origin. So if you see here, ameloblastoma is always above the inferior alveolar nerve canal. This is your inferior alveolar nerve canal and ameloblastoma is above this inferior alveolar nerve canal. Yeah. When you talk about Staphne bone cyst on the other hand, so this Staphne bone cyst is always below the inferior alveolar nerve canal. So it is definitely not odontogenic in origin, बल्कि ये तो cyst है ही नहीं, ये तो just एक lingual salivary gland depression है. Moreover, Paget's disease or fibrous dysplasia, if they occur in mandible, they are always below the inferior alveolar nerve canal. Okay. But if the pathology is within the canal, देखो ये pathology कहाँ है? It is within the canal. So if the pathology is within the canal, so usually the pathology is neural in origin, or we can say it's vascular in origin. So neural pathology is within the canal, or a vascular pathology, its epicenter is also within the canal. So it is very important. जब आप diagnosis बना रहे होंगे ना, just make sure the epicenter where it is. Above the canal, below the canal, inside the canal. Right? Coming down now. Further, there are lesions which are single, and there are lesions which are multifocal. Periapical cyst is usually single, but leukemic infiltrates are multifocal. You know, sometimes in an OPG you may notice presence of multiple infiltrates, radiolucent. So if you see such multiple infiltrates which are radiolucent, consider presence of leukemia. So leukemic infiltrates also sometimes appear as multifocal radiolucencies in an OPG, right? However, they are very uncommon, तो मैं इतना time waste नहीं कर रहा हूँ इसके ऊपर. They won't be asked. But a cyst which is usually multifocal and which is asked every year because it is multifocal, that we all should know. And that cyst is this. Multiple OKC. कितनी बार पूछा गया है? Monday also we discussed that multiple OKCs are seen in Golden-Goss syndrome, bifid rib, nevoid, basal cell carcinoma syndrome. So multiple OKCs, last to last, back to back questions are there on multiple OKCs, and your answer will always be Golden-Goss syndrome, and that we have already discussed, right? If you remember, we have discussed that we can differentiate many pathologies on the basis of size, students, right? You all know that periapical granuloma is small in size, periapical cyst, it is large in size. Similarly, students, follicle, hyperplastic follicle and dentigerous cyst. Remember, we can differentiate on the basis of size. Small follicle is 2 to 3 mm. Hyperplastic follicle is 3 to 5 mm. But if that follicle or that radiolucency which is attaching at CJ is more than 5 mm, then it is definitely a dentigerous cyst. So this is also important that we should know. You remember these shapes? We have corticated border, we have sclerotic border, we have soft tissue capsules, right? So corticated border is seen in cyst. Sclerotic borders we usually see in tumors. Corticated border is thin radiolucent border. Sclerotic border is thick radiolucent border, and some lesions have soft tissue capsule, that is center mein they are radiopaque but they have radiolucent rim around it, like cementoblastoma and odontome. I'm sure all of you know about it. मुझे इसमें दोबारा आपको बताने की ज़रूरत नहीं है. मैं केवल आपको कुछ images दिखाने वाला हूँ अभी जो आपको clear cut बता पाएंगी that this is important. Tell me what borders are present in fibrous dysplasia. You can see this picture, and just by seeing this picture, I'm sure you are going to tell me that what borders are seen in fibrous dysplasia. याद करिए students. When we talk about fibrous dysplasia, 5 MCQs we usually get. 5 MCQs we usually get. Firstly, the borders. The borders of fibrous dysplasia are blending type. The borders of fibrous dysplasia are blending type, where the normal and the abnormal bone, they blend with each other, right? Also, we know that fibrous, yes, very good, that in fibrous dysplasia the trabeculae are granular and we have characteristic ground glass appearance. Apart from ground glass appearance, we have that pewdy orange and orange peel appearance also. Pewdy orange and orange peel appearance also. Apart from that, sometimes in fibrous dysplasia we have that thumbprint appearance also, right? So few important questions you will usually find in context of fibrous dysplasia, and you know that fibrous dysplasia is unilateral and it is common in maxilla. Unilateral, common in maxilla, right? Of course, malignancies have ill-defined destructive, because malignancies are destructive. So malignancy के जो borders होते हैं, they are ill-defined and invasive type. Ill-defined and invasive type. देखो कितना destruction cause कर रही है ये malignancy in this picture, right? I'll just show you the important ones. Just a second. when I see the time now, I actually feel that there is too much pressure to complete so many things and time हमारे पास हमेशा छोटा सा होता है. So students, this is simple, but again आपके एग्जाम में ये आया हुआ है, so you all must be knowing this, that what you see is a heart-shaped radiolucency between the roots of central incisor. Heart-shaped radiolucencies between the root of central incisors. And this is nasopalatine duct cyst. This is nasopalatine duct cyst. Right. So heart-shaped radiolucencies between two central incisors is nasopalatine duct cyst. And if you see inverted pear-shaped radiolucency, which is present between maxillary lateral incisor and canine, this is globulomaxillary cyst. Inverted pear-shaped radiolucency, what you see here is globulomaxillary cyst, and this is present between the roots of maxillary lateral incisor and canine. Right, students? And what you see here is now dentigerous cyst. You know we have three types of dentigerous cyst: central, lateral, and circumferential type. Here, because the roots have not formed completely, so what we see is a circumferential type of dentigerous cyst. Correct? And a large dentigerous cyst which arises from a cystic lining will be a unicystic ameloblastoma. Correct? AOT पे क्वेश्चन आया है स्टूडेंट्स एसोसिएटेड विद कैनाइन. देखो, dentigerous cyst is associated with impacted third molar. The cystic lining always attaches at CJ and it is never mixed. It is always this thing, radiolucent. But AOT, what you see here, देखो ध्यान से, this is AOT. It is most commonly associated with maxillary canine. Most commonly associated with maxillary canine, and it does not attach at CJ. It attaches somewhere at root, and it usually can have calcifications also. So this is AOT, adenomatoid odontogenic tumor. You have MCQs on this adenomatoid odontogenic tumor also, right? Going on to the next slide, which is important. I'm not showing all these things which usually don't are not asked. I'll show you the important ones. Remember students, do remember this lesion also. This is called as cemento-ossifying fibroma. This is another mixed lesion which is called as cemento-ossifying fibroma. This is cemento-ossifying fibroma, usually well-defined, dome-shaped and mixed, right? Usually seen in the mandible. So cemento-ossifying fibroma, all these mixed lesions, if you remember, I have told you that they start as unilocular radiolucencies. Slowly they become mixed. So, and the cemento-ossifying fibroma, it usually appear mixed. It usually appear mixed only. Cyclus dysplasia we have discussed. Paget's disease is bilateral. We have bilateral cotton wool appearance. When we talk about Paget's disease, we have bilateral cotton wool appearance. We discussed on Monday that with Paget's disease, we have hypercementosis associated. Right. Remember students, you may have questions on osteosarcoma also. You may have questions on osteosarcoma also. Now, osteosarcoma, remember students, the initial sign is that you have widening of pedial space in 4 to 5 teeth. So just remember, if you are confused that you have to mark answer as osteosarcoma or not, बहुत ध्यान से देखना. If you have widening of pedial space around 4 to 5 teeth, तो समझ जाना osteosarcoma है. And if you have clear-cut sunray appearance like this, then also you are very sure that the question they have asked is on osteosarcoma and they are expecting answer as osteosarcoma, right? When we talk about multilocular radiolucencies, you all know that ameloblastoma clear-cut multilocular है, round septae है, soap bubble honeycomb appearance है, and there is knife edge resorption, what you see here, right? You have such knife edge root resorption seen. You also know that this ameloblastoma, it causes lot of buccolingual expansion, as you had that question. So that buccolingual expansion is also this such a great buccolingual expansion is characteristic of ameloblastoma, having this soap bubble or honeycomb appearance. And if you have straight septae, remember, if you have straight septae like this, then it is tennis racket appearance, which is characteristic of odontogenic myxoma. If you have straight septae, then it is tennis racket appearance, which is अच्छा, now I can see the thing. मेरा वो मिस, मेरे बीच में options मिस हो जाते हैं. Yes, Khushi, even in scleroderma we have, sorry I missed out questions what you asked. In scleroderma we have generalized widening of pedial space. Very true, generalized widening of pedial space. Yes. Coming back to this, yes, tennis racket appearance where straight septae is present, that is seen in odontogenic myxoma. Very good. So this pathology यहाँ पे देखो कितने clear cut straight septae हैं. So this is odontogenic myxoma what you see here, right? So ये ना ऐसे टेबल एक आप याद कर लो स्टूडेंट्स, बहुत ही बढ़िया है. If in a question you have buccolingual expansion and you see honeycomb or soap bubble appearance and they show you knife edge resorption, root resorption, तो समझ जाना they are expecting answer as ameloblastoma, that too in the posterior mandible, right? Similarly, in the posterior mandible, if they show you straight septae, that means they are expecting answer as odontogenic myxoma, right? Similarly, if in the posterior region they show you such scalloped border, very less buccolingual expansion, more of anterior posterior expansion and multiple, तो समझ जाना they are expecting answer as OKC. Regarding CGCG is present in anterior region at a very young age, 17 to 21 years में present होता है, and it has wispy septa. At right angles to the periphery. Yes, wispy septa, Khushi, at right angles to periphery. Wispy septa at right angles to periphery. If this is there, that means they are expecting CGCG as answer. यही कुछ क्वेश्चंस पूछ के आते हैं और आपसे पूछ लिया जाता है. Okay. Sorry. So again straight septa. So this is odontogenic myxoma. Again you see straight septa here. So it is odontogenic myxoma. Right. OKC and all अब मैंने बहुत दिखा दिया आपको. Quickly we'll just switch these slides. हाँ, ये भी आता है question. ये बताओ क्या है? Let me see who will answer this. Which lesion is, which pathology is this? Which pathology do you see here? On your screen, which pathology? Anyone? This is, अच्छा मेरा मुझे लगता है मेरे chat चला जाता है. This is cherubism, students. The lesion is bilateral. देखो, bilateral ramus involvement. Bilateral ramus involvement is there. Here also multilocular lesion. Here also multilocular lesion. Both the sides you have multilocular lesions. So what you see here is cherubism. Absolutely cherubism. अगर आपको दिखे mixed dentition and you see a child with bilateral involvement of multilocular lesions, they are expecting cherubism as answer from all of you. Alright, students. So please remember that. Condensing osteitis, cementoblastoma, all this I have shown. Condensing osteitis with an infected tooth, cementoblastoma with a vital tooth, and having that radiolucent peripheral rim, that is soft tissue capsule. So this is cementoblastoma. ये पिक्चर को अपनी आंखों में बसा लो because cementoblastoma is also important and many times you get question on cementoblastoma as well. So ये पूरा अपनी आंखों में ना इसको भी आप बसा लीजिए, important है. And in the anterior region, we have compound orentome. So this is anterior region. Multiple tooth-like structures having peripheral radiolucent rim. So yes, this is again orentome. Yes, this is again orentome. And which orentome? Compound orentome, anterior region. And this is complex orentome in the posterior region, which is appearing as ill-defined calcified mass, and it has got that peripheral radiolucent rim or soft tissue capsule, posterior region. So this is complex orentome. This is complex orentome. And again, students, if you have this cotton wool appearance in all the 4 quadrants, cotton wool appearance in more than 2 quadrants or in all the 4 quadrants, please remember it is florid cemento-osseous dysplasia. It is florid cemento-osseous dysplasia. Florid cemento-osseous dysplasia. Okay. Calcifications and all, cyalolith, I'm sure you all are going to answer. Cyalolith इतना मुश्किल नहीं है आप लोगों के लिए. आप the last PPT which I am going to show you is this. ये मैंने आपको पहले भी दिखाया है. Don't worry, nothing is tough here. Very simple. But थोड़ा सा medicine part I wanted to show so that see all of you are answering. आप लोग खुद देखो, all of you are answering. So you all are perfect. So this is the first slide which I am going to show you here. And in this first slide, what lesion we see? If you see very carefully, we see erosive lichen planus. बस 5 मिनट मेरी बात ध्यान से सुन लो students. I'll finish the class very soon. But just listen to me for 5 minutes. If they will ask a question on erosive lichen planus, they will mention there white striae, or they will show you such white striae, and if this red erosive component is also present, it will be erosive lichen planus. If they show you desquamative gingivitis on gingiva also, they show the red areas, again understand this is desquamative gingivitis and they might be expecting answer erosive lichen planus from you, isn't it? It is autoimmune, and remember nowadays it is said that it is associated with hepatitis C virus. Cobenous phenomena. In the lines of trauma, new lesions are formed associated with lichen planus and psoriasis. Again, this question is asked, right? Very important differential diagnosis of erosive lichen planus we discussed is discoid lupus erythematosus. Monday हमने discuss किया था, where we have central red area and peripheral radiating striae like sun ray. या उसको ऐसे बोल दो, striae they are coming and they are joining at a single red atrophic area in the center. So that will be discoid lupus erythematosus. If they mention any etiology that these striae are adjacent to a restoration or in a patient who is on drugs or is taking tobacco, then your answer will become as lichenoid reaction. So बहुत ही ध्यान से आप सुनना. Lichen planus is very common these days, so might be you are getting any picture based, image based question on lichen planus, right? Similarly students, herpes zoster is very important, and you may get a picture based question on herpes zoster. देखो lips पे अगर कुछ दिखा रहा है, so mostly they are asking herpes labialis, but herpes labialis, am I not audible? Am I not audible to everyone? Am I not audible to everyone, or Naveen, you please check your this thing. I think ऑडिबल है ना, ठीक है. सो if they are asking herpes labialis, जब आपने previous years papers किए तो you must have seen lot many questions on herpes labialis. So herpes labialis will be on the lip or corner of the lip. But अगर इतना diffuse presentation है students, देखो lip के साथ साथ you can see that chin area is also involved and you notice that the lesions are unilateral. You notice that the lesions are unilateral, then do understand it is herpes zoster infection. Unilateral जहां पर भी आ गया, it is herpes zoster infection. Herpes zoster infection. I will just increase the volume. Now it is fine. I think now my volume will be fine. So what do you see here is herpes zoster infection. Remember, herpes zoster infection is very important. Herpes zoster infection is very important and you may get a picture based question. And associated with herpes zoster infection, that Ramsay-Hunt syndrome, always remember, where you have facial palsy. That Ramsay-Hunt syndrome is important where you have facial palsy. Alright. And whenever you see such hemorrhagic crusting of lips and target lesions, we discussed on Monday also, they are talking about erythema multiforme, usually erythema multiforme. So this is the case of erythema multiforme that you see on your screen. Very important is your proliferative verrucous leukoplakia. Very important is this proliferative verrucous leukoplakia, which is usually seen on lower gingiva. It has that verrucous surface, cauliflower-like surface, and remember students, it has got the highest malignant conversion rate. It has got the highest malignant conversion rate. Please remember. Okay. Then cobblestone appearance and all, ये सब हम discuss कर चुके हैं. I'm sure you people are aware of this thing. Any one thing which I can show you which is important is I'll show. Alright, I think this is okay. Smoking is, I think, leukoplakia, OSMF, candidiasis, denture stomatitis, all those things I think you all can properly diagnose. उसमें तो कोई difficult है ही नहीं. Stretch पे disappear होता है, that is leukodema. I think ये सब common lesions, other common lesions I'm sure हम लोग discuss कर भी चुके हैं. That you can also see. Right. So students, there is a long way to go. I can just keep on discussing these things, so many things with you all. But most important, previous year's questions we discussed on Monday also, and today I discussed it in the form of pictures so that very well we can understand, and all those questions I compiled also. Whatever I have revised was important. Whatever I revised had come in the previous years, and everything is important. I again repeat, oral medicine, I am sure आपका prepared है. हम लोग इतना revision कर चुके हैं. Focus on the more important questions. Right students, I am ending the class now, and you all please prepare well, and all the best for your exam. Do well. Don't forget me. I love you all. You are our asset, and all the best. I can only give my blessings. हार नहीं मानना है कभी भी, किसी भी चीज से हार नहीं मानना है. आप लोग बहुत अच्छा करोगे. Don't forget that. You have that power. अच्छा बुरा जो हो, it's okay. Focus on important subjects. You will get a good rank.